Okay. So what I want to do is I want to take time and do the practice problems that I put up on the classroom. Boop, boop, boop. And then we'll kind of talk through different stuff. I found some really good tips and tricks, different stuff like that. So where I want to start is talking about this table. So we're going to go through this table. I'm going to handwrite everything. So you could use this to kind of organize your thoughts. There's some pretty good ways of organizing the different bacteria out there. Do you need to know which ones are coag negative and coag positive, all that kind of stuff? Or like, okay. So you just need to know that different tests exist, but not necessarily um, how they work. Because that was really more microbio than it is. You need to know about like hemolysis probably, but I don't think she really focuses on it because that's really more microbio. All right. So let's talk about gram-positive bacteria. What are our four major categories of gram-positive bacteria? Very good. Staph, strep, entero, and Clostridium. These are the four major categories. Are there other bacteria as well? Yes. There's Listeria, there's Bacillus, all that kind of stuff. But for the most part, these are four major categories. Like you guys have pointed out, we can have subcategories like MRSA. And then within strep, what kinds of strep do we have? Oops, this entire thing is all messed up. There we go. So within strep, we have strep epidermidis, we have strep pyogenes, strep pneumoniae, and then there's the Viridans group and all that kind of stuff, but we're not going to particularly worry about it. All right. There are three kinds of enterococcus that we should talk about. And then we'll get into like hemolysis and stuff like that in just a second. But does anybody remember the three kinds of enterococcus? Tell you that they start with F. Phasalis, yep, and Faecium. And then what do we call enterococcus that is resistant to certain antibiotics? VRE, vancomycin-resistant enterococcus. We're very resistant. All right. So for our, as we, kind of know, enterococcus is sort of kind of a type of strep. And so we can further differentiate the different bacteria based on what kind of hemolysis they have when they're on a blood agar plate. The biggest thing to know is that as you go down, as you go from alpha, beta, gamma, you have different amounts of hemolysis. So what kind of hemolysis is the worst? What kind of hemolysis eats 100% of the blood that's in the agar? Beta. Very nice. I went back to my microbiome notes, and beta is bad. So beta is the kind of bacteria that will eat through your the lining of the throat, cause really, really bad sore throat, stuff like that. What is partially complete hemolysis? Gamma. And then, so we have 50%, and then we have alpha. Very nice. All right. Yes, I feel the same way. Enterococcus is gamma. Some hemolysis. Strep pyogenes is beta. All other kinds of strep are alpha. So like epidermidis, pneumoniae, all that good stuff. What do you really need to know about the hemolysis is really, I think, more about this rather than remembering, which are what kind of hemolysis. So be familiar with what hemolysis is rather than trying to pick it to different things. I think that's really more the important part. All right. Finally, so we talked about the different kinds. So which ones are our cocci? Staph, strep, enterococcus. And then what does that mean Clostridium is? Rod. By the way, all those other bacteria like Listeria, Corynebacterium, Actinomyces, those are all rods as well. And then what I'll tell you is which one is our anaerobe out of these four major groups? Clostridium. There are two other kinds of anaerobes as well that are gram-positive, Peptococcus and Peptostrepto. And I think you just need to know that they are anaerobic, right? Or that maybe or you don't have to know which drugs are anti-anaerobe, right? At this point. So does that mean that everything besides staph, strep, and enterococci, not those two. Oh, yes. 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 So the reason I don't tend to list them is because they're not the four major bacteria that are talked about in this first section. Peptostrepto and Peptococcus aren't a major focus among the different antibiotics, but they are cocci. They're just anaerobes. All right. Any questions about these? All right. So in terms of our chart here, gram positive all the way down. Cocci, and the only rod is uh, the only rod is Clostridium, and then the only anaerobes are Peptococcus, Peptostrepto, and Clostridium. Might actually be better. Let's fill out this chart. This is, I think, a better way of organizing the material. All right. So of our four major locations, where do we normally find Streptococcus? Where do we think? Yep, definitely oropharynx, which really this should be the oropharynx. Where else? One other major location. Not the urinary tract, skin. Staph epidermidis, right? Epidermis, skin. Yeah, strep. Oh, that is, you are right. My bad. I literally just said staph, didn't I? Not paying attention. All right. Staph then is oropharynx and skin. How about practice worksheet is when you go in the classroom, it'll be under classwork. Oh, put your email in the chat and I'll make sure to add you at the end as well. Oops. Oop, actually, this is the link to join. All right. How about Enterococcus? Where can we find Enterococcus? Gut. 100% the gut. Peptostrepto and Peptococcus. Where do we find those? These are going to be our above the diaphragm. So these are our mouth anaerobes. Oropharynx, which means that Clostridium is our below the gut anaerobes. So when you think anaerobes, I'm just going to kind of clue you in here. just so that way we can talk it all at once. There are 4 anaerobes that we worry about right now. Peptostrepto and Peptococcus are the ones in the mouth, where Clostridium and Bacteroides are in the gut. Everything else is aerobic. So if it's not PPCB, then it's not anaerobic. All right. What about all these ones down here? Neisseria, Moraxella, Haemophilus, Pseudomonas. Gram negative or gram positive? Gram negative. Which ones are our gram negative cocci? Enterococcus is Neisseria and Moraxella. What I will tell you is that Haemophilus is a special one where it's a combination of the two. So it's called a coccobacillus. Everything else is a rod. Am I missing one? These aren't in the right order. Oh, no, they are. I'm just missing one. Missing 3. Neisseria, yeah. Missing E. coli, Proteus, Salmonella. So what I've done here is I've organized them by their shape. So as much as possible, I tried to keep things connected so you can see them. So here you can see Neisseria, Moraxella, only gram-negative cocci. Everything else is a rod, where Haemophilus is like this in between. Where do we find, let's go with an easy one. Where do we find Pseudomonas? Usually. Where does it tend to pop up in infections? In the lungs. Yep. So I'm just going to put oropharynx just to keep things kind of consistent. How about Haemophilus influenzae? Where do we find influenzae? Lungs as well. Yep. So if you had to guess based on the kind of pattern that's going on, these are oropharynx as well. Everything else is gut. So I think it helps to go to the answer key here because it's a little bit easier to see. But what I've done is I've organized them so it's really, really, really clear. Whoops. What is what and what does what. Now, what I want to do is I want to. No. I want to put like a really thick bottom border, but don't think it's going to be. Well, oh well. Does this kind of help organize the bacteria? Is this helpful for you guys? Okay. All right. Again, this isn't the not all of these bacteria are normally found in the body. And the biggest thing here is oops, that should be oropharynx. I kind of put other things that I saw, like Enterococcus can infect the urinary tract. Really, it's the only one. It kind of ruins the pattern, that sort of thing. But here it is for you. Any questions about this? All right. Now that you guys are so good at doing the bacteria, let's go through the drugs. And I hear you all collectively groan. Oops. All right. We need to make these a little bit bigger. Oops. So I think it's actually easier for us to start with the delete. What do I want to do? I want to freeze the top two rows. View and freeze pane. There we go. I think it's actually easier to start with the cephalosporins because their trending is a little bit easier. For the most part, this is generalizing across groups. A lot of times you'll have specific bacteria that is better than others at certain things. Why is this? Doing this? Okay. So let's start with the cephalosporins. First gen cephalosporins. So what kind of drugs are we talking about first gen cephalosporins? Good question, right? What even are they? So, yep. So for first gen, big one PO is Keflex, cephalexin. And then for IV, cefazolin. Those are the two big ones. When we talk about first gen cephalosporins, do they have good gram positive coverage? So do they cover staph and strep? Yes, they do. So in terms of staph and strep, These drugs are very good at what they do. Do they cover enterococcus? No. In fact, do any of the cephalosporins cover enterococcus? Not really. So I wish I could put like an X in all of them. So none of the cephalosporins are good for uh, enterococcus. Will any of them cover VRE then? No, right? If you can't do regular enterococcus, you can't do the resistant enterococcus. How about MRSA? Where do we tend to see MRSA pop up? 5th gen, ceftaroline. So of all of our gram or cephalosporins, we see no enterococcus, and ceftaroline is the only one that covers MRSA. 4 cephalosporins in general, do they all cover streptococcus, or do only some of them? The chart has 6. Yes, all of them cover streptococcus. Where we lose activity is once we start with that 3rd, 4th gen. At the 3rd, 4th gen is where we start to lose staph activity. We gain it back with ceftaroline, but we lose it after the 3rd gen. Any questions? All right. Skipping the anaerobes for a second. We'll come back to them. Here we have H&M and then PEC, right? Proteus, E. coli, Klebsiella, where the S is for staph and strep, right? For our cephalosporins, does the 1st gen cover H&M? No. Does the 1st gen cover spec? So staph, strep, and then Proteus, E. coli? Yes. Everything else, H&M spec. The 2nd gen not cover staph? Oh, you're right. My bad. Right, because we lose it and then we gain it back. Did I have that right in the... Should probably be following... Oh, I have to fix that. Yep. Does it have enterococcus? Yes, because it's broad spectrum. Oops. There we go. So other than the 1st gen, we have broad gram-negative coverage. What really changes depending on the different generations is what we're doing with gram-positive. We're always covering strep, and only the 1st, 3rd, and 5th cover staph. What I will tell you is that for yeah, I think it's because the third gen and the first gen have similar side chains. That's why. What I will tell you is that Bacteroides is our gram. Oh, okay. Odd. Oh, ha ha ha. Um, Bacteroides is our gram negative anaerobe. So it makes sense that with our later generations, we cover gram negative anaerobes. All right. So now the question becomes, what generation do we pick up Pseudomonas activity? Who has Pseudomonas activity? Some of them do. We'll start with the easy one. Would ceftaroline have Pseudomonas? Fifth gen generate, definitely, right? Cefepime, which is that weird third, fourth gen one, definitely does. Oop. Fourth gen does. And what I will tell you is that some drugs in third gen do. Some, depending if they're A or B. I think ceftriaxone does. Is this helpful, by the way, going through it like this? Okay. All right. Again, if I'm ever doing something that's not useful, let me know. Actually, that's it. Pretty sure it does. Maybe it doesn't. Some do. Some definitely do. I'm gonna leave. All right. Um, and that is those. Ceftazidime. Okay. So in terms of the way that we can label our drugs, what I say for this is that the first gem is just spec, right? First gen is just spec. Second gen, H&M spec. Three through four, we gain Pseudomonas. And then finally, fifth gen, MRSA, H&M spec, and Pseudomonas. Any questions? All right. Aztreonam. Yeah, this view is like really bad. Aztreonam. Does Aztreonam have any gram positive coverage? Would it work on anything gram positive? Answer is no gram positive coverage. What it does have is H&M. H&M PEC. It picks up Pseudomonas as well, which means that in terms of how we label a bacteria or antibiotic, H&M PEC. That's it. No spec. All right. Carbapenems. Do carbapenems have broad gram-negative coverage? Yes. Very, very good gram-negative coverage. They also cover Pseudomonas. So they are H&M, PEC, and Pseudo as well. Essentially what they do is they pick up the ability of ceftaroline plus the in gram-positive plus the gram-negative. So they're kind of like the combination of ceftaroline or just a non-MRSA version of ceftaroline. Aminoglycosides are very, very similar. The only difference is that they don't cover strep. Strep? Am I crazy? Yes. All right. Just to fill in our anaerobes for a second. If aztreonam is gram-negative coverage, of our 3 anaerobes, which one is it going to cover? Of our 3 anaerobes, which one is it going to cover? Just Bacteroides. Why? Because Peptostrepto and Peptococcus are gram-positive, and C. diff is gram-positive as well. Carbapenem is broad gram-negative and gram-positive. So are we going to be able to cover Bacteroides? Yes. Are we going to be able to cover Peptococcus and Peptostrepto? Yes. Will it touch Clostridium? No. Because we know that there's only one drug that covers Clostridium for the most part, at least in terms of your list that you have right now. One drug for Clostridium. Any questions so far? Is this chart helping, not helping, putting things in perspective? Okay. That's the big thing. My goal when putting together these charts was to give you a very visual, very comprehensive way of looking at the bacteria and the spectrums, because this shit is tough. Very tough. All right. So this is our kind of first block of oops. Of antibiotics. Oops. All borders, and then I want a thick outside border. Because it's important to know. It really is. These are questions that, especially if you work hospital and your plan is to do hospital rotation, you will get asked these questions. 100%. We were asked these questions all the time. There wouldn't be enough time. Really, if Viro had 2 semesters, it would be a lot better. Because next exam you're going to have even more antibiotics to learn. So this is why I say you have to know your bacteria now. Have to know your bacteria now. All right, vancomycin. Vancomycin is a broad gram-positive antibiotic. So it is going to work on staph and entero. Staph and strep, and it covers entero and MRSA. It is our drug that is going to work on C. diff as well, but what's the only form of vancomycin that works on C. diff? PO. Great. Vancomycin has no gram-negative coverage. How about the vancins? So one of the issues with vancomycin is now we have resistance to it. So what does the vancins do? What are they picking up? VRE. How about linezolid? Same thing. What about our lipopeptide like daptomycin? Same thing. So this is our second block of antibiotics, the vancomycin type antibiotics. Any questions about these? Let me double check if it covers peptostrepto. Yes. Yes. These as well. Forgot about the anaerobes. And I need to update the answer key though. Makes sense, right? Covers the gram-positive anaerobes. All right. Going up to our penicillins. The penicillins are probably the most difficult because they don't have as easy of a trend that we can kind of plot out, right? With our cephalosporins and the other beta-lactams, we can kind of see that we're gaining gram-negative coverage, gaining Pseudomonas coverage, and then we have some kind of random-ish gram-positive coverage. It's really with the penicillins that have the most difficult kind of overarching. What I will tell you is that all of them cover strep, enterococcus. They're all very, very good at strep and enterococcus. Except for, I think I went too broad. No. Nope. Okay. Yes, because it's them. Kind of. Not really. Of our penicillins, which one is going to be covering staph? There's just one. Who covers staph? Is it going to be our penicillin VK, cloxacillin, oxacillin, ampicillin, and amoxicillin. Right. So the only one here, right, oxacillin, dicloxacillin, those sorts. Very nice. As we go up in generations, we get more and more gram-negative coverage. So our first two quote-unquote generations of penicillins, no gram-negative coverage. Or if there are, it's very unreliable and not worth using. Where we see them pop up is for amoxicillin and ampicillin. We see them pick up Proteus, E. coli, and Haemophilus. What I will tell you is that really we focus on these two, Proteus and E. coli. And our extended spectrum is doing HKP, Haemophilus, Klebsiella, and Pseudomonas. What should you really focus on for the aminopenicillins? You should really be able to pick out which ones are working on staph, which ones are working on Pseudomonas, and then let's talk about the anaerobes. So it makes sense that when we talk about gram-negative coverage, our later generations are covering Bacteroides. And then I just want to double check, actually, because I didn't check it earlier. Where would this be? And positive cockeye, peptostrepto. Yeah, okay. I believe it's this for peptostrepto and pepto. Any questions? I see, I thought that as well, because I have it in my chart, but I couldn't find it. Yeah, I think this is more accurate. Yeah, because I was looking at it and I don't have it written down, but I couldn't remember if I purposefully did it or left it out by accident. All right. Any other questions about these? So like I said, you must know your bacteria. You have to. You it will save you so much headache going forward in this class. being able to just know the bacteria in the spectrum. I know it's a tough, especially with the other classes you have it going on. But I'm not someone who's very good at rote memorization, but this is the kind of thing that memorizing it just makes your life a whole lot easier. It really does. If your memory is not as great, then you have to do more work, unfortunately enough. All right. Here's some questions that I wrote up, looking at kind of the different ways that the questions are written on the exam for Rudolph's portion specifically. So TR is a 56-year-old male who presents to the emergency department with a chief complaint of nausea, vomiting, and abdominal pain. His current medication list is lisinopril, atorvastatin, toprolol, succinate, and metformin. His abdomen is very tender. He has some different labs. Which of the following bacteria are you most concerned with in TR based on his presentation? So, what is the location that his infection is taking place? Gut. Somewhere in the abdomen, right? When we talk about internal kind of gut infections, stuff like that, what can we cross off right away? Staph. Yep. Staph is primarily the skin and the oropharynx. What else can we get rid of? Pseudomonas. When you think Pseudomonas, I want you to think pneumonia. Aeruginosa, air. So think lung. Streptococcus as well, right? A lot of this is oropharynx. That sort of stuff. What about C. diff? Do we cross off C. diff? Could be C. diff. Yep. Because this is in the gut. Could it be Enterobacter faecalis? Yeah, 100%. And then how about E. coli, Escherichia? Yeah, all three of these. By the way, if you're like me and you saw faecalis and you're like, oh, it's the face, this is feces. That's what it's talking about. Faecium, also feces. Cultures were sent off and returned with evidence of gram-negative rod growing in TR. Which of the above bacteria would you be concerned with? So it's not going to be any of the ones that we crossed off. And so what does that leave us? This should be select all that apply. Not C. diff, right? Enterobacter and E. coli. At this stage in the game, these are the questions you should expect regarding bacteria, right? Location and categorization. Well, waiting for speciation. So what this means is that we know it's a gram-negative rod, but we don't know, specifically if it's Enterobacter, E. coli, maybe something else. Doctors want to treat him with a broad-spectrum gram-negative antibiotic. So which of the following antibiotics would be the best choice in this patient? What can we get rid of right away? What do we know is just not going to be a good option? Moxicillin. Well, talk about it in a second. People are saying amoxicillin, Vanco, Diclox. So let's talk through Vanco. What is Vanco known as? Where is its utility usually? Anti-MRSA. Also, so we know it's covering staph, strep, enterococcus. What about dicloxacillin? What category or what class of antibiotic is dicloxacillin part of? Dicloxacillin are penicillin-resistant penicillins. Penicillinase resistant. Anti-staph. Yep. So that means that what is dicloxacillin normally going to be working on? Anti-staph, strep. Staph and strep. So gram positive. How about amoxicillin? What's the utility of amoxicillin? So amoxicillin has good staph and strep. Good strep. I mean, enterococcus, right? Which, as we know, is sort of like a streptococcus, and it has some gram-negative coverage. But if we're waiting for speciation and the doctors told us that we want broad spectrum, are we going to rely on amoxicillin? Probably not, right? Does amoxicillin cover E. coli? Yeah, but we don't know if it's E. coli. We just know it's a gram-negative rod at this point. Could be Proteus, could be tons of other stuff, right? I can't think of them. Maybe Bacteroides. We don't know. What about Keflex? Uh what class is Keflex from? First gen. When we talk about first gen cephalosporins, what are we talking about? What acronym? Spec, right? So we're talking about staph and strep, Proteus, E. coli, and Klebsiella. Does it have broad gram-negative coverage? No. It's one of the only cephalosporins to not have first gen don't have broad gram-negative coverage. So that leaves us with cefepime. What generation is cefepime? Very close. It's the weird one. Third, fourth gen. Uh, yeah, right? Am I crazy? It's the weird one. No, it is fourth. Squarely in fourth. No, yes, squarely in fourth. Fourth gen. All right, let's talk about some things to remember about cefepime. Specifically about, let's talk about beta lactams in general. and then we'll talk about cefepime and other cephalosporins. So what are some things that we need to remember about beta-lactams in general? So they apply both to penicillins, cephalosporins, carbapenems, aminoglycosides, all that kind of stuff. Yep. A lot of them are going to have nausea, vomiting, diarrhea. What's one organ that we have to monitor the function of while we give these drugs? Kidney function, right? So most of them are renally dosed. There's only one drug that is biliarily secreted. What's that one drug? Does anybody remember? Oop, just bring up my notes. Very nice. Nafcillin. Now, a lot of these drugs have biliary plus renal excretion. So they're a combination of them. This would be ceftriaxone, and our anti-staph penicillins. When we talk about the concern with kidney failure, or sorry, renally dosed, what are we concerned with? Renal insufficiency, right? What are some drug-drug interactions that we have to think about? Yep. Loop diuretics. What else? Think sodium. Yep. ACE inhibitors. And really, we should just broaden this and say diuretics in general. ACE inhibitors, because these guys are affecting RAS, right? Digoxin, not because of sodium, but because of potassium. And lithium. Very nice. The reason is because lithium exchanges for sodium in the renal tubule. And so we worry about, the extra sodium load that we're giving. Great. All right. What are some disease states that we need to monitor when we talk about beta-lactams in general? So talking about cephalosporins, beta-lactams, carbapenems, all that kind of good stuff. Hypertension. Yep. CKD. Yep. Any kind of renal insufficiency, AKI, all that kind of stuff. Heart failure. Kind of connected to this as well as edema because of the sodium controlling where the water is going. Yep. 100%. And then in terms of adverse drug reactions, what are some major ones that we have to worry about, specifically when we talk about things like that's for all beta lactams? Seizures. Yes. Yes. 100%. What's also something that we should always ask our patients before we give them any beta lactam? Allergies. Very nice. Have you guys talked about type of allergies yet, or just if there are allergies? Like a type 1, type 2, type 3, type 4? Okay, I think that's next exam. All right. All right. Let's go into the next question. We'll bring up other stuff when we come across them. Exam, I will say that going through Viro, all of us kind of thought like, wow, we're learning things that we could probably make a difference in people's lives. Viro kind of makes you feel that way. Fourth year is kind of the year that you're like, wow, maybe I am a pharmacist. It just sucks that it's such a fucking hell to get through. All right. Which of the following could be used for methicillin-resistant Staphylococcus aureus infections? This is a question that I pulled directly from one of her review packets. So this is a very big Rudolph question. So when we talk about methicillin resistant, we're talking about MRSA. So what about Vanco? Can we do Vanco? Yep, 100%. I see Teflaro, which is ceftaroline. What else? Which one of these is like an improved version of vancomycin? Linezolid. When I think linezolid, I think oral Vanco. That's what I think of, because linezolid is an oral drug. Meropenem, tobramycin, which, by the way, what is the drug class of tobramycin? Was this on your list? I think it should be on your list. Yeah. Aminoglycoside. I like the mycin choice. All right. So our answer here is 1, 2, and 5. 1, 2, and 5. Which ones are going to work anti-Pseudomonas? Which ones are anti-Pseudomonas? Dobra. Nasal. So what can we get rid of right away? What do we know? Actually, first of all, what is Pseudomonas? Gram negative or gram positive? Gram negative. So with that in mind, what can we get rid of right away? What do we know is not going to cover gram negative at all? Vanco and linezolid, right? Because linezolid is an improved version of Vanco. So this leaves us with the question of, when we talk about our anti-pseudomonal drugs, so cast your ideas back to the chart that we just filled out. So we had the 1, 2, 3, 4, 5 CPN. We had aztreonam. We had aminoglycosides and carbapenems. H&M spec and Pseudomonas. Which out of this block of drugs, what can we get rid of right away and says does not cover H&M spec? So broad gram negative. We could definitely say not first gen, but second gen does cover H&M spec. Everything else is broad spectrum. Oh, we mean HM man. Huh? Oh, I see. Oh, that's my bad. All right. So other than the first gen, we don't get broad gram negative coverage. What generation do we see Pseudomonas coverage pop up? Third generation. So we have some in the third generation and then all the way down. So would ceftaroline? Yes. Meropenem? 100%. Tobramycin? Yes. Any questions? Is this helping? Kind of put things in perspective, how to use the chart, how to do these different things. Okay. Not very useful if I hand you a chart and we don't end up using and kind of understanding how it works. My boyfriend is playing with bugs right now. All right. You're working in a hospital and receive a call from a nurse about a patient in the ICU. Shortly after beginning vancomycin infusion, the patient developed a rash on their face and their skin was warm to the touch. What should be done before the next infusion? Discontinue vancomycin and immediately administer epinephrine since they're having an anaphylactic response. Check the trough level of the drug, and if above 20 micrograms per milliliter, continue the next infusion. Check the trough level of the drug because this is a reaction to the drug level being too high, or continue the dose. So this is a really good question. If someone has a rash, does it necessarily mean that they are having an allergic reaction? No. So when I was looking through specifically the information that Rudolph gives on the red man syndrome, she talks about the hypotension, she talks about the flushing. And a lot of times what this presents as, or what people think, is that it looks like a rash. The biggest thing about that's the part that is difficult about a lot of these vancomycin questions, especially when we talk about like an allergy to it. It is a histamine reaction, but it's more due to just kind of broad degranulation. So actually, I think this is better if we just kind of let's talk through what's going on here. When we talk about allergic reactions, uh, uh, okay. Uh, how can I best explain this? Ah, okay. I know how we're going to do it. A lot of times what ends up happening when we talk about the red man syndrome is it's all dependent on uh, the time that the medication was administered for. So if you look at pictures of red man syndrome, a lot of times you look at it, and especially for um, someone who may not know any better, you look at a picture of red man syndrome and you go, "Holy shit, look at that rash!" Right? It looks like a really, really bad rash. So one of the things that can end up happening is that when you get a call up to the floor and someone says, our patient has a major rash, what should we do? It uh they look at this and they go, "Oh my God, we're going to have to administer epinephrine." So one of the things that ends up happening is that rash by itself is kind of the term that gets thrown around when you get called up about vancomycin. What's important though is the time after infusion. For red man syndrome, we're talking 4 to 10 minutes after beginning the infusion. It's an immediate reaction. Whereas usually the allergy is delayed by, you know, 30 minutes, 45 minutes, a little bit later. One of the biggest uh one of the biggest things to know about what's going on here is that you have very, very, very fast uh degranulation of mast cells, which is causing a big release of histamine across the entire body. What you guys will learn next exam is that when we talk about allergy, we're talking about antibody. Uh, the antibody is what's causing the anaphylaxis. So for people who the first time that they're exposed to an allergen, like the first time they get a bee sting or the first time that they get penicillin, the allergy takes time for the body to develop antibodies, and then every subsequent time they get faster and faster and faster. With red man syndrome, there's no immune involvement. It's purely just the mast cells release all of their histamine at one time, and then that's how you end up getting this big, what looks like a rash presenting all over the body. So, what to do when we have someone who's presenting with vancomycin and we we have this rash, we have to look at how quickly they developed it. So according to the problem, are we seeing a delayed response or an immediate response? What kind of clues us in? Immediate, right? How do we know? Because it says shortly after, right? So almost immediately after beginning the vancomycin infusion, this starts to pop up. This clues us in that we're dealing with a red man syndrome rather than a pure allergy, despite it saying, oh, we have a rash. So the thing that we do with the red man syndrome is we slow the infusion rate. So the answer is D. Let's talk through what these other situations are talking about. So for C, we have a trough level it's talking about a trough level that's above 20 micrograms. What's the correct trough level for vancomycin? What are we looking for? 15 to 20. When we talk about a level above 20 micrograms, what are we at risk for? What could possibly develop? Nephrotoxicity. Yep. Ototoxicity. 100%. Those are the big ones. What else are we worried about with vancomycin at really high levels? Neutropenia. Yep. Um, neutropenia is more for long-term use. That's where we tend to see the neutropenia. So not necessarily just the high doses, but more that we're using it for a long amount of time. And then of course, irregular nausea, vomiting, diarrhea. What happens if we have less than 15 micrograms? What's going to happen here? Yeah, it's not working. So you're not actually going to kill the bacteria. What is likely to develop? Resistance, right? So if you have subtherapeutic doses, then you might end up with VRE. You might end up with, delaying treatment, lots and lots of different issues. Very nice. Any questions about 5? Does it make more sense? Maybe, sort of. Okay. All right. BT is an 85-year-old female and presents to the ED with signs of lower respiratory infection, pneumonia. Her med list includes metoprolol, succinate, enalapril, furosemide, warfarin, and sertraline. While waiting for cultures, doctors would like to begin broad-spectrum empiric therapy that covers MRSA and Pseudomonas. So which of the following regimens would accomplish this? So based on what we talked about earlier, should have a pretty good idea of what is going to cover Pseudomonas and MRSA. So let's look at piptazo. What does piptazo cover? Everything, right? Super broad spectrum. So with piptazo, we have good gram-positive and pretty good gram-negative coverage. Primarily, what are we going to be using piptazo for? What's a good thing that piptazo covers, especially when we talk about resistant bacteria? Oh no, I'm thinking about the wrong thing. Right? Am I crazy? No, I'm thinking about the wrong thing. All right, cefepime. What is cefepime covering? What acronym are we going to use to describe cefepime? H&M spec. Yep. What about Pseudomonas? Yes. So if you remember, third gen and down, we get Pseudomonas coverage. Vanco. What is the utility of using Vanco? Gram-positive coverage, specifically MRSA. No gram-negative coverage. What about linezolid? Same thing. Great gram-positive, MRSA. And then what are we picking up with linezolid? What's that other resistant bacteria that Vanco won't touch? VRE. Nice. Meropenem, carbapenem. Is this below the third gen cephalosporin in our chart? Yeah. So this means it covers H&M spec plus Pseudomonas. Same thing with the aminoglycosides. They're below our third gen H&M spec plus Pseudomonas. All right. So in terms of what is going to be gram broad MRSA and Pseudomonas, this would be our 2 and 3. Any questions about this? Does piptazo cover MRSA? Can't ever remember. No, it doesn't. That's right, because it doesn't cover MRSA. It's huge gram-negative coverage. That's why. I always ampicillin, sulbactam, and piptazo. I always get confused. So let's talk through a couple of things here, a couple of these different drugs. I want to talk about the penicillins real quick. So when we look at natural penicillins, like penicillin VK, benzethiazine, penicillin G, stuff like that. What's one of the big characteristics of penicillins that we have to be really careful about when we administer them? What's something that gets co-administered and we can't really get rid of it? Sodium. Lots and lots of sodium. One of the big things that she talked about in the packet was if you're giving 20 million units of penicillin, G, something like that, you're giving about 23 milligrams of sodium. That's a huge amount of sodium, especially if you're giving it every 12 or 8 hours, right? So you have to be very careful with the sodium load that you're giving people. Another good thing to bring up is that no aminoglycosides. You can't combine, I'm just going to put this as penicillins in general, no combinations with aminoglycosides. Like we talked about earlier, allergies, seizures, that kind of stuff. Of course, hypertension, cardiovascular disease, all the drug-drug interactions we talked about, that sort of stuff. Yes, that's a good point. Insane. Yep. All right. Penicillinase resistant penicillins. So what are these drugs? Which one is our oral? Diclox. The other ones are IV. Very nice. Same sort of issues as the natural penicillins. What's one of the major drug-drug interactions that we worry about with this category specifically? Warfarin. As well as, diuretics, ACE inhibitors, lithium, all that kind of stuff. So are we going to increase or decrease the INR with, let's talk about it this way. What's going to happen to warfarin concentration? Are we going to increase or decrease the absorption? Decrease. So this means that are we going to have a higher or lower INR? Decrease. So INR is a function of how much anti-clotting we're doing, right? So higher INR, less clotting. So if the INR is going down, more or less, more. So what is someone at risk of if they're on warfarin and they're taking dicloxacillin at the same time? Thrombi, right? They're at risk of stroke, heart attack, all that kind of stuff. All right. Aminopenicillins. Two really, really, really big drugs here. Ampicillin and amoxicillin. Which ones are which? IV and PO. It's better actually if I do it like this. We all know about amoxicillin. It's the quintessential delicious PO drug. Ampicillin, IV, PO. The bubblegum solution, delicious. Big thing about amoxicillin. Should people take it with or without food? With food. 100%. Ampicillin, how should they take it? Without. Personally for me, I don't get diarrhea with amoxicillin. I get vomiting. Really, really bad vomiting with amoxicillin. NVD. Not fun. All right. Diarrhea is the big one, though. We have some other specific drug-drug interactions when we talk about, especially amoxicillin, so it's because it's so common. So again, we pick up warfarin. What are the two other ones that we worry about? Allopurinol, specifically because it can cause a rash. So it leads to higher concentrations of allopurinol. And then oral contraceptives, specifically with estrogen. And so what do we tell people to do when they're on an oral contraceptive? Use secondary protection. Wear a condom. Wear a helmet. I like that. All right. That's really, yeah, we don't have to go too much. Oh, I wanted to talk about linezolid. Linezolid. Couple of things we have to be aware of with linezolid. What's one of the major um uh bu- 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 yes, thank you. Actually, on my rotation with Rudolph, I presented about how linezolid doesn't really have it doesn't really cause serotonin syndrome, which was, it's interesting. So two really big facts about linezolid. It has an effect on the CNS and it has an effect on the bone marrow. As someone quickly shouted out, serotonin syndrome is one of the big ones that we worry about. Why? What does linezolid do that makes it have this serotonin syndrome? MAO, MAO, MAO. So interactions with MAO inhibitors, SSRIs, triptans, all that stuff that works on the serotonin syndrome. What is the other thing it's doing in the CNS? There's two other things it's doing. Neuropathy, yep. Peripheral neuropathy, optic nerve. Great. So, what is linezolid doing to the bone marrow? Is it causing suppression or is it accelerating the bone marrow? Suppression. What are the three kinds of cells that are created by the bone marrow? Red blood cells, white blood cells, and the platelets. What disease state results because you have decreased your red blood cells? Anemia. What about white blood cells? Neutropenia. Right. You're generally we call this pancytopenia. Right? We're decreasing everything. And then what's the risk of if your platelets are low? Thrombocytopenia, right? We're bleeding. Thrombocytopenia, neutropenia, anemia. Great. So another one I wanted to talk about. Nope, we'll talk about those later. Yeah, great. Yes, reversible after 2 weeks. Yep. Or within 2 weeks, about 2 weeks. All right. JH arrives at urgent care for a skin infection on his arm that won't go away with OTC topical antibiotics. Doctor decides that he must be started on a regimen to treat his uncomplicated skin infection in an outpatient setting. Which of the following would be most appropriate to start? So let's go through these one by one. Keflex. Can we give this in an outpatient setting? Yeah, 100%. Keflex is an oral drug. So there's actually two components of this we have to talk about. What are the two things that we have to consider for this problem? What's the first major consideration? Right? That we have a skin infection, and we're talking about an outpatient setting. So when we talk about skin infections, what are we primarily thinking about? Staph. Yep. And strep. Could it be other things? Yes. What is it most likely? It's probably staph. Could it be strep? Possibly. But usually those are the ones that we're going for. All right. When we think about outpatient, what are we thinking about? Oral only. Should we give him, well, what about like ceftriaxone? Because you can do intramuscular ceftriaxone. No, we do not expect our patients to do ceftriaxone. IM because it's true they won't do it. They won't take it. Plus it hurts. I think it's a pretty large dose. So Keflex, definitely PO drug, has good gram-positive coverage. What is the IV version of Keflex? I'll give you a hint. It starts with Cef. Very close. Not ceftriaxone. Cefazolin. All right. What about penicillin VK? Can we give penicillin VK? 100%. Penicillin's a good choice. Covers strep, won't cover staph, but Maybe that's what they want to go for. Yeah, it when I came up with this question, I think I had two things here, but I might have deleted it. Doesn't no staph, but it does cover strep. Oh, you know what it was? Is that I put this question because I wanted to talk about PO versus IV. That's why. So no staph, but all right. Dicloxacillin. Can we give dicloxacillin? Yeah, 100%. What's the IV versions of dicloxacillin? Nafcillin, oxacillin, all that good stuff. What about ceftaroline? No, not at all. Ceftaroline is our 5th gen cephalosporin. This is an IV only drug. And does it cover skin infections, staph and strep? Not really. It doesn't cover staph, does cover strep, but what are we primarily using these later generation cephalosporins for? Gram negative. Is there an oral version of ceftaroline? Meaning, is there a different drug that would work orally? In the same class? No, there's no oral. How about amoxicillin clavulanate? Clavulanate. Can never say this. Yes, 100%. What is the IV version of this drug? Ampicillin, sulbactam. Right? If we have one of the inhibitors, we want to make sure we're keeping the inhibitor. What about vancomycin? Yep, unison. What about vancomycin? That's available PO. Nope, can't do it. Only for C. diff. What is the oral version of Vanco that I keep telling you about? Linezolid. That's how I think of it. What about gentamicin? Nope. Gentamicin, IV only. Do we have any oral aminoglycosides? Nope, none at all. The reason is because they are very finicky dosing, right? So we have to monitor very, very closely. What about regular ampicillin? So not ampicillin sulbactam, but just regular ampicillin. Yeah, 100%. Ampicillin sulbactam is PO and ampicillin by itself is PO and IV. So we can just give it alone. Its combination with sulbactam, I'm pretty sure, is only IV. And then finally, ceftriaxone. What generation is ceftriaxone? 3rd gen. Can't give it. IV only. It's also IM. What is the other IV 3rd gen cephalosporin? ceftazidime. And then what's the oral third gen? Cefpodoxime. Cefuroxime is second, but it is oral and IV. Great. Any questions about this problem? Is this problem helpful? I feel like it is. Okay. All right. Last one, and then we'll wrap up. 5-month pregnant woman is being treated inpatient for a multi-pathogen abdominal infection. She has a past medication history of diabetes, depression, high blood pressure, and hypercholesterolemia. Her current medication list is insulin aspart, fluoxetine, and nifedipine. Which of the following antibiotics would be contraindicated in her? Yes. Aminoglycosides cannot be given in pregnancy. Highly teratogenic. Can they be given in breastfeeding, though? So you have a mother who is breastfeeding. Nope. Can't give it in breastfeeding either. It's just harmful to kids in general. Oh, congratulations, Ibram. I bet Pierre's the father. Yeah, so this is why I kind of put this in here just as a reminder is that pregnancy is something that we worry about a lot with many, many drugs, especially when we talk about antibiotics. Pregnancy changes the body, right? Because now you have more tissue growing, more fluid going. You have to worry about the placental barrier. So there's a lot of things to say about pregnant patients. And going forward, you're going to learn certain drugs that you cannot give to pregnant women, pregnant women, breastfeeding women, and children. And for this exam, you don't really have that distinction. Next batch of drugs, you definitely will. Breastfeeding children. We generally breastfeed children. I think. And that is the end here. All right, great. I think tomorrow we will do the medchem portion just to get through. No, no. I'm gonna record that. You guys have whatever it's called on Tuesday, so no session tomorrow, but there will be Tuesday, Wednesday. Right? Am I crazy? No. What day is exams Wednesday? Oh, we're not doing a session Tuesday. That's what it is. Right. That's what it is. So I will post that schedule right now. All right. I will see you all tomorrow. Tomorrow we will do the medchem portion together because there is some stuff that I want to talk about. Let me know if you have any questions. And if you guys don't see the recording up tonight, let me know and I'll make sure to put it up.